Welcome to This Explainer. Today, we're diving straight into why a femoral hernia is absolutely not your run-of-the-mill complaint. Seriously, this is a high-stakes clinical emergency. If you've ever found yourself wondering why a certain groin lump is totally fine for watchful waiting, while another means rushing a patient straight to the OR, well, you're in exactly the right place. You see, the crucial takeaway here is learning to distinguish between an everyday, benign presentation and a ticking time bomb where tissue strangulation is a very real, very imminent threat. Think of it like an inner tube bulging through a weak spot in an old tire. When a loop of intestine pushes through the abdominal wall, you get a lump. But as we're going to see, the exact anatomical location of that tiny hole literally dictates whether you can safely observe it or if you need to sprint that patient to surgery. So here's our clinical roadmap for today. We'll start with the anatomy and the actual defect, then compare femoral versus inguinal hernias. After that, we'll hit the severe symptoms and complications, move right into diagnosis and imaging, talk about surgical repair, and finally, look at a really fascinating, rare case of female genitalia herniation. All right, part 1, anatomy and the defect, the femoral canal. Let's get right into it. To really grasp the pathology here, I want you to picture a tight, completely unyielding box. The front boundary is your inguinal ligament, the back is Cooper's ligament, also known as the pectial ligament, the outside lateral edge is the femoral vein, and the inside medial edge is the lacunar ligament. Normally, this canal just holds some lymphatics and loose tissue to give the femoral vein some room to expand. But because this space is so incredibly narrow and walled in by tough, rigid ligaments, any tissue that gets jammed in there is highly, highly vulnerable to getting trapped. Okay, moving on to part 2. Femoral versus inguinal hernias, the rule of contrasts. So let's contrast these two. Inguinal hernias are super common. They make up about 70 to 75% of cases, mostly affect men, and pop up above the inguinal ligament. On the flip side, femoral hernias only account for about 3 to 5% of all hernias. A fantastic mnemonic to anchor this in your memory is simply female equals femoral. They almost exclusively affect women, especially older patients or those who have had multiple pregnancies, which really stretches out that pelvic region. And crucially, they appear below the inguinal ligament. But here is the massive takeaway. The strangulation risk for femoral hernias is just dangerously high compared to inguinal ones. Which brings us right into part 3. Symptoms and severe complications. A surgical emergency. Now, patients are typically going to present with some pretty alarming symptoms, signaling that a previously painless lump has suddenly trapped a piece of bowel. Unlike a standard inguinal hernia, where you might easily feel a cough impulse, that cough impulse is actually often absent here. Instead, the patient might complain of sudden, severe stomach pain or even hip pain, which can easily trick you into thinking it's just a joint issue. But listen, if they have a tender, irreducible globular lump below the inguinal ligament and they're throwing up or have a rapid heart rate, you absolutely must suspect an intestinal obstruction. And this rapid progression from an incarcerated hernia to a strangulated one is exactly why this is a massive surgical emergency. When the hernia gets physically stuck in that rigid anatomical box we mapped out earlier, it's incarcerated, it's trapped. But when those borders squeeze down so tightly that they completely choke off the blood supply, that's when it becomes strangulated. This is bad news. It releases harmful toxins right into the bloodstream and can incredibly quickly lead to tissue necrosis, gangrene, sepsis, and even death. Let's jump to part 4, diagnosis and imaging studies, finding the defect. So, while a thorough physical exam is always your initial step, ultrasound is an absolute game changer here. Point-of-care ultrasound, or POCUS, gives us a stunning 97% sensitivity rate. It's our gold standard first-line imaging study. Why? Because it allows clinicians to immediately confirm the diagnosis, actually visualize the defect in the muscle wall, and check for trapped bowel, all without exposing the patient to a single drop of radiation. This 3-step diagnostic pipeline guarantees a really swift, systematic approach. First up, physical exam. And keep in mind, femoral hernias can be tiny and hidden deep in thigh tissue, especially in overweight individuals, so you really have to look for it. Second, you bring in the ultrasound to visualize the defect. And third, if the diagnosis is still a bit murky, or if you suspect a severe complication like strangulation or bowel obstruction, you get a CT scan. A CT provides a highly detailed, comprehensive anatomical map to guide your immediate surgical intervention. Next up, part 5, surgical repair and management. Fixing the canal. So, how do we fix it?
Well, whether you're utilizing an open, tension-based approach like the McVeigh technique, which literally stitches the structures down to that tough Cooper's ligament we mentioned earlier, or opting for a modern, minimally invasive laparoscopic repair with 3D mesh placement, the ultimate goal is exactly the same. The surgeon has to safely pull back those trapped contents, double-check the bowel's viability to make absolutely sure no gangrenous tissue is left behind, and then permanently reinforce that tight femoral space so this doesn't happen again.
And finally, Part 6, Rare Female Genitalia Herniation, a Fascinating Case Study. Okay, you have got to hear about this truly extraordinary presentation. We are talking about a 28-year-old female patient who came in with a really painful left groin lump. During emergency surgery for what they thought was a standard strangulated femoral hernia, the surgeons were shocked to find that her hernia sac actually contained her uterus, her left fallopian tube, and her left ovary. I mean, wow. Because the femoral canal sits way below their normal anatomical position, finding these organs in there is incredibly rare and is likely tied to a congenital anomaly. But here's the good news. The organs were totally healthy, safely reduced back into the pelvis, and the hernia was completely repaired. So what does this all mean for you? Keep the severity and the rigid nature of that tight anatomical space front of mind for your clinical practice. That small lump below the inguinal ligament, it's not something to just brush off. It might literally be a ticking time bomb. The real question is, will you recognize it before the clock runs out? Thank you so much for joining me for this explainer. If you found this helpful, please hit that like button and make sure to subscribe to the channel so we can keep bringing you more high-quality medical deep dives. Stay curious, trust your diagnostic instincts, and I'll see you in the next one.